You know that heart-pounding moment? You're just standing at the bedside of a neuro patient, and your eyes are completely locked on the monitor.
Oh, yeah. You're staring at a waveform, just holding your breath.
Exactly. You're wondering, is that subtle change in their breathing just a normal quirk of sleep? Or is it a life-threatening emergency unfolding right in front of you?
And the nervous system is pretty notorious for that, honestly. It doesn't always give you, like, loud, obvious warnings before things go wrong.
Right.
A patient can look completely stable and then, shift into a critical state in a matter of minutes.
And as a newer nurse, it kind of feels like you're expected to just magically sense it. But today, we're taking the magic out of it, and we're replacing it with pure, highly tested physiology.
Love that.
Welcome to a special edition of the Super Nurse Podcast. I want to state really clearly right at the top that this show is created by Brooke Wallace. She's a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author.
We should definitely add our standard disclaimer right here. We are not Brooke Wallace.
No, we are definitely not Brooke, but this entire session is built directly from her bedside knowledge, her clinical notes, and, her signature teaching style.
Yeah, it's designed specifically to help nursing students and new nurses bridge that massive gap between textbook theory and real hands-on patient care.
Absolutely. And I want to warmly invite you to subscribe and watch the video version of this very session on YouTube. The link is right down in the description, and the channel is called Super Nurse AI.
You'll definitely want to check that out. So our mission today is a comprehensive 2026 NCLEX Neurological review.
Right.
We're breaking down how the human brain actually works under duress, specifically how it responds to injuries, diseases, or emergencies. And we're going to distill the absolute must-know bedside safety priorities.
Because, the brain is uniquely vulnerable compared to the rest of the body.
Yeah.
You injure your arm, the tissue swells, the skin stretches, right? The inflammation has room to expand.
But the brain doesn't have that luxury.
It really doesn't.
Let's start right there with the physical mechanics of the skull. It is a rigid, unyielding bone box. When things go wrong inside, the pressure has absolutely nowhere to go.
Nowhere at all.
Which brings us to the fundamental rule of neurological nursing, the Monroe-Kellie Doctrine.
Right, the Monroe-Kellie Doctrine. So inside that bone box, you have exactly three things. You've got brain tissue, blood, and cerebrospinal fluid, or CSF. The doctrine states that if the volume of any one of those increases, say from like a bleeding vessel, a tumor, or swelling from an infection, one of the other two just has to decrease to make room.
They have to compensate. The body might shunt CSF down into the spinal cord or make it reduce venous blood flow to make space for the swelling.
But that compensation only lasts so long, right?
Exactly. Normal intracranial pressure, or ICP, is between 5 and 15 millimeters of mercury. When that pressure rises greater than 20, the compensation is failing. The brain is literally getting crushed.
And the 2026 NCLEX RN test plan specifically expects nurses to know how to monitor and maintain these internal ICP devices. Recognizing that pressure spike early is just everything.
It is. Because if that pressure isn't relieved, the body goes into a desperate final survival maneuver.
Cushing's Triad.
Clinically, yes, we see this as Cushing's Triad. It's a late, super ominous sign of impending brainstem herniation.
Okay, so what exactly does that look like on the monitor?
It involves 3 specific vital sign changes: systolic hypertension with a widening pulse pressure, bradycardia, and irregular respirations.
Okay, let's unpack this for a second, because this used to trip me up completely.
Oh, it trips everyone up.
Right. Physiologically, it just feels totally backwards. Usually, if a patient's blood pressure shoots up, like if they're stressed or in pain, their heart rate goes up right along with it. They rise together.
That's the normal response, yeah.
So why does the heart rate plummet when the blood pressure is skyrocketing to like 190 or 200?
It's completely counterintuitive until you look at the mechanics. And understanding this is how you actually remember it for the floor.
Okay, break it down.
As ICP rises, the pressure inside the skull becomes so intense that arterial blood physically cannot push its way into the pressurized vault. The blood is hitting a wall of resistance.
Wow, a literal wall.
Yes, and because of that, the brain is essentially starving for oxygen. So the ischemic brain triggers a massive sympathetic response to drastically spike the systolic blood pressure.
It's trying to force it.
It is literally trying to forcefully blast oxygenated blood up into the head to overcome that resistance.
Okay, so the top number, the systolic, goes way up, trying to act like a battering ram.
Yeah.
But the diastolic, the resting pressure, stays normal or even drops,
Exactly.
which gives us that widening pulse pressure. The gap between the two numbers just gets larger and larger.
Precisely, but here's the mechanical catch. Those massive blood pressure waves are hitting the baroreceptors in your aortic arch. Yeah. The body senses this dangerously high pressure in the systemic circulation, and it just panics. It thinks it's going to blow a vessel.
So what does it do?
It triggers the vagus nerve to slam the brakes on the heart, causing the heart rate to drop dramatically, and that is your bradycardia.
Wow. So the body is literally fighting itself. The brain is screaming for blood, but the heart is being told to slow down because the pressure is just way too high.
It's a catastrophic feedback loop, and meanwhile, all that pressure inside the skull is physically crushing the brainstem down at the base.
And the brainstem controls breathing.
Right. It houses your respiratory centers. So as it gets distorted, you see erratic, irregular respirations, often called Cheyne-Stokes breathing.
Which means if you see that triad at the bedside, a skyrocketing systolic BP, a dropping heart rate, and weird breathing patterns, you are not just watching a subtle change.
Not at all.
You're in a code-level emergency. The brainstem is herniating.
Yes. And understanding these intense pressure dynamics is a total cornerstone of bedside safety.
Absolutely. Because when you see the pressure climbing in that rigid skull, a very logical, albeit really dangerous thought might cross your mind.
What's that?
You might think, well, there's too much fluid in there. Let's drain some off. Or maybe you suspect an infection is causing the swelling, so you think, let's do a lumbar puncture to test the spinal fluid.
Oh man, doing that without checking the pressure first is lethal. Performing a lumbar puncture, or LP, is strictly contraindicated in a patient with severely elevated ICP.
Right. The best analogy I ever heard for this is thinking of the central nervous system like a bathtub full of water.
Okay, I like this.
Doing an LP on a high ICP patient is basically like pulling the drain plug while a high-powered industrial vacuum is running directly underneath the pipe.
Wow, yeah.
The high pressure up in the skull isn't just going to slowly, politely leak out.
No, it won't. What's fascinating here is that the high pressure will violently shift downward to find that lowest pressure point.
The release valve.
Right. The brain physically gets vacuumed downward and herniates through the base of the skull, the foramen magnum. And that is often instantly fatal.
Which is terrifying.
It is. This is why assessing for signs of increased ICP, like an altered level of consciousness or sluggish pupillary changes, before an LP is a highly tested concept. Providers will almost always order a CT scan of the head first.
Just to make absolutely sure there's no mass effect or dangerous swelling before they ever let a needle near the spine.
Exactly.
But let's say the CT scan comes back clear, though. No massive pressure risk, so the physician goes ahead with the lumbar puncture. Once that procedure is done, our bedside nursing care shifts entirely to recovery.
And stabilization, yeah. We have to lay them flat for 1 to 2 hours afterward to prevent spinal headaches.
Push fluids, right, to rehydrate that cerebrospinal fluid volume.
You got it. And we're usually performing that LP to hunt for invaders in the first place, specifically the bacteria or viruses that manage to breach the blood-brain barrier.
Like meningitis.
Yes. Meningitis is an inflammation of the meninges, those protective membranes wrapping around the brain and spinal cord.
And it produces a very specific, miserable cluster of symptoms at the bedside. You always hear about the classic Triad high fever, the worst headache of the patient's life, and neutral rigidity.
The stiff neck.
Yeah, I always memorized the Triad, but I never really thought about the mechanics behind it. Why the intensely stiff neck?
It basically comes down to mechanical stretching.
Yeah.
The meninges coat the entire spinal cord all the way down the neck.
Okay.
When they're inflamed, they become incredibly raw and sensitive. If a patient flexes their neck forward like chin to chest, it physically pulls and stretches those inflamed meninges.
Ouch, so the body just fights it.
Exactly. The body's defense mechanism is to violently spasm the neck muscles to prevent that painful stretching. That is neutral rigidity.
That makes total sense. And what we know from practice is these patients almost always have photophobia too.
Oh, extreme sensitivity to light.
Right. You walk into the room, turn on the fluorescent overheads, and they will physically recoil.
Because the bright light stimulates the optic nerve, which in turn pulls on those irritated meninges at the base of the brain.
It's all connected. You'll also see nausea and vomiting quite frequently, especially in viral meningitis, which is heavily tested.
But if you suspect bacterial meningitis, your absolute first priority as a nurse isn't dimming the lights.
Nope.
And it isn't hanging the antibiotics. It is initiating droplet isolation precautions.
Protect yourself, protect the other patients, protect the staff, put on the mask.
Isolate first. Always. Then you obtain the blood and CSF cultures. Only after the cultures are drawn do you start the broad-spectrum antibiotics.
Because if you give antibiotics first, you can sterilize the blood or spinal fluid just enough to ruin the culture results.
Right. Meaning we might never know exactly what bug we're actually fighting.
And while those antibiotics are working, we keep that room dark, quiet, and we stay hypervigilant. Because all that swelling and inflammation is sitting right on top of the cerebral cortex.
And when the brain's electrical system gets irritated by inflammation,
it tends to short out. Which brings us to seizures.
yes. During a generalized seizure, the brain is misfiring rapidly. The patient completely loses control of the body, their airway, and their consciousness. Strict bedside safety protocols are just paramount here.
I have to admit, my very human instinct as a neuro nurse during a patient's first big tonic-clonic seizure was to protect their tongue.
Sure.
You hear all these myths about people swallowing their tongues, so the gut reaction is to want to grab a bite block or like a tongue depressor and wedge it in there.
That is a very common instinct, but the evidence tells us you never, under any circumstances, put anything into a seizing patient's mouth.
Nothing at all.
No tongue blades, no fingers, no bite blocks. The jaw muscles are spasming with incredible force. If you try to force something in, you'll cause severe dental fractures or push broken teeth down into their airway.
Or you might literally lose a finger.
Honestly, yes.
And I think another huge instinct is to run out into the hallway and scream for the doctor or sprint to grab the crash cart.
Also a hard no. You never leave an actively seizing patient. Your presence is their primary lifeline.
So what do you do while you're in the room?
You focus entirely on safety and the airway. Ensure the bed is in its lowest position. Pad the side rails. Move any hard objects out of the way.
And you should already have suction and oxygen set up at the bedside from your beginning of shift checks.
Oh, absolutely should. That's a day one habit.
I'm also looking at my watch the second the seizure starts. Because timing is everything.
Time the seizure, always. If it crosses the 5-minute mark, the patient has entered status epilepticus.
Which is a huge emergency.
A profound medical emergency. The brain is consuming massive amounts of oxygen and glucose while they're seizing, and they aren't breathing effectively. It requires fast-acting IV benzodiazepines like lorazepam or diazepam to chemically halt the electrical misfiring.
And once the shaking finally stops, they enter the postictal phase. They don't just wake up and say, hey, what happened?
No, they're exhausted, deeply confused, drowsy, or even completely unresponsive.
Which means your assessment has to be meticulous. Post-seizure care requires a thorough evaluation of their airway, breathing, level of consciousness, and vital signs.
Because their gag reflex might be compromised, and they're highly sedated from the exhaustion, so they're at a massive risk for aspiration.
So we immediately roll them onto their side, the rescue position. That way, all the pooled saliva or oral secretions drain out onto the pillow instead of sliding down their trachea into their lungs.
Perfect. And we can use that bedside suction we set up earlier to help clear the airway while they recover.
Awesome. And we spent time on the electrical failures and the pressure issues. But a massive part of neurological nursing involves the brain's plumbing.
The blood vessels.
Right. Brain attacks, cerebrovascular accidents, or strokes. This is where a clot blocks a vessel, completely starving the downstream brain tissue of blood and oxygen.
That's your acute ischemic stroke. And the assessment here has to be rapid and incredibly precise. B-FAST is the classic initial detection tool.
Balance issues, eyes meaning sudden vision loss or double vision.
Face drooping, arm weakness, speech slurring, and time.
But once that patient hits the emergency department or the neuro floor, BE-FAST just isn't enough. We move to the gold standard for objectively quantifying stroke severity.
The NIH Stroke Scale, or NIHSS.
Exactly.
The NIHSS is a 15-item physical exam.
Yeah.
It's rigorously standardized. You're testing level of consciousness, visual fields, facial palsy, motor strength in the arms and legs, sensory loss.
And language deficits like aphasia and dysarthria.
Right. It's scored from 0 to 42. Like golf, a lower score is better. A 0 means no measurable neurological deficits. A 42 is profound catastrophic impairment.
I always wondered why we test certain things so specifically on that scale. Like, why are we testing visual fields by wiggling fingers in their periphery? What does their eyesight has to do with a blood clot in their brain?
It actually tells you exactly where the blockage is. The brain is perfectly mapped out. Visual processing happens in the occipital lobe at the very back of the head. But the optic nerves run all the way from the eyes through the middle of the brain to the back. If a clot blocks the middle cerebral artery, it starves those nerve pathways.
Wow.
So a loss of peripheral vision isn't an eye problem, it's a massive clue about which pipe is blocked deep inside the brain.
Here's where it gets really interesting, though. Let's say a patient comes in and scores a 1 or a 2 on the NIHSS.
Okay.
Maybe they just have a tiny bit of arm drift or a very slight facial droop. Is that really a code-level, drop-everything emergency? I mean, does a score of 1 justify activating the whole stroke team and rushing to CT?
It absolutely does, and this requires a crucial mindset shift for nurses. You cannot just treat the number, you have to treat the patient's functional life.
That's a great point.
A score of 1 or 2 can still be a devastating emergency. Imagine that patient is a neurosurgeon or a graphic designer or a concert pianist.
Wow, yeah.
Minor hand weakness isn't just a clinical symptom to them, it's a life-altering disability that ends their career and completely changes their independence.
When you frame it like that, losing fine motor skills in one hand is completely catastrophic.
And that is why the prevailing mantra in neurology is, time is tissue. Millions of neurons die every single minute a vessel remains blocked.
So if the stroke is confirmed to be ischemic by ET scan, meaning there's no bleeding, just a clot, the primary medical intervention is TPA, a powerful clot buster.
But it has a very strict administration window.
Right. It must be administered within 3 to 4.5 hours from the last known well time. And that is such an important distinction. It's not 3 hours from when they arrived at the hospital triage desk.
No, definitely not.
It's from the last moment someone saw them acting completely normally.
Exactly. If a patient goes to bed at 10 p.m. feeling fine and wakes up at 6 a.m. with a facial droop, their last known well time is 10 p.m. They are an 8-hour stroke.
Which means they are outside the window for TPA.
They are.
Which feels terrible to tell a family. You want to say, we have this medicine to fix it, but you just can't give it. But there's a very solid physiological reason for that strict cutoff.
There really is. If you force that plumbing open too late, the blood vessels downstream are already dead and necrotic. They are friable.
So they're super weak.
Yes. If you blast a powerful blood thinner and restore high-pressure blood flow into those dead pipes, they will simply burst. You will convert an ischemic stroke into a massive hemorrhagic stroke.
Oh, man. So blood will leak directly into the brain tissue.
Yep, which causes a massive spike in intracranial pressure, bringing us right back to the Monroe-Kellie Doctrine and Cushing's Triad.
It's amazing how everything in the skull is so tightly connected.
It is a very delicate ecosystem. Now, we've covered the acute, sudden emergencies, the pressure spikes, the electrical misfires, the ruptured plumbing, but a huge percentage of neurological nursing isn't fast and acute.
It's gradual. It's the slow, chronic neurodegeneration.
Yes, the tangled wires, cognitive and perceptual alterations, primarily Alzheimer's disease and other forms of dementia.
As a nurse, you are going to care for Alzheimer's patients constantly, no matter what unit you work on.
So true.
They come in for like a urinary tract infection or a broken hip or pneumonia, but their primary barrier to receiving care is their dementia.
And to care for them safely and effectively, you have to understand what the disease is doing structurally to the brain. For many dementia types, the frontal lobe is attacked and degraded very early on.
And the frontal lobe is essentially the CEO of the brain, right?
Exactly. It controls reasoning, sequencing, impulse control, and the ability to process complex instructions. So when an Alzheimer's patient gets profoundly angry or refuses their medications or yells at you, they aren't being intentionally defiant.
No, they're just...
Their frontal lobe has literally lost the structural hardware required to reason.
I think about how overwhelming a standard hospital routine is for someone with completely intact cognition, let alone an Alzheimer's patient.
Oh, it's a sensory nightmare.
Right. We bring in a tray full of food wrapped in plastic. We expect them to sit quietly in a loud, bright room at a strange table and use utensils for a 30-minute meal. But clinical experience shows this is a complete disaster for a dementia patient.
It's pure cognitive overload. Highly tested nursing interventions actually involve monitoring their food and fluid intake because sitting for that standard meal is often impossible for them. They get agitated and just walk away.
So we have to adapt. Instead of forcing them to sit with a fork and knife, we offer high-calorie finger foods, things like chicken nuggets or sandwiches, that they can hold and eat safely while they're pacing the halls.
We adapt the environment to their reality.
Yeah, exactly.
Yes, and we must strictly minimize environmental noise and distractions during meal times. Turn off the television, close the door, remove the clutter from the tray.
Keep it simple.
The analogy I like to use to explain their agitation is to imagine opening a drawer full of tangled wires. When an Alzheimer's patient is confused, their brain is that knot of wires.
I love that visual.
When a well-meaning nurse tries to argue with them or corrects their memory or gives them long, multi-step logical explanations, the nurse isn't fixing the problem, they're just pulling the wires tighter.
Like saying, don't you remember you're in the hospital? Your daughter just told you that 5 minutes ago. You say that, and the knot just tightens. They get more defensive.
Because to argue, you need an intact logic center to understand cause and effect. Correcting them just triggers shame, anxiety, and a feeling of being threatened. Providing care in a non-threatening, non-judgmental manner is a vital strategy.
So when they are incredibly upset and looking for their husband who passed away 10 years ago, the absolute worst thing you can say is calm down. I mean, has telling someone to calm down ever worked in the history of healthcare?
Never. It is the least effective phrase in the English language.
Totally.
Instead, you validate their emotion. You don't validate the incorrect reality, but you validate the feeling behind it. You say, I see that you are worried about your husband. Tell me about him.
That is so much better.
You lock eyes, use a calm, low-pitched tone, and use reality-based diversions to safely redirect them to another activity. Your stable, regulated nervous system becomes their medicine.
Wow, your stability is their medicine. That is such a powerful way to look at it. And honestly, that concept applies to every single thing we've broken down today.
It really does. The brain cannot protect itself from these insults. It relies entirely on the nurse's clinical judgment.
It means that the brain is this incredibly delicate, highly pressurized organ, and its physiology dictates exactly how we must care for it. Your safety protocols like questioning an LP order on a patient with high ICP, or your rapid NIHSS assessments to save a stroke patient's tissue, your absolute vigilance in protecting the airway during a seizure, and your calm, adaptable tone with an Alzheimer's patient.
They're everything.
Those aren't just arbitrary hospital policies. They are the ultimate physical and emotional protective barriers for your patient.
Beautifully said. Recognizing the subtle signs before irreversible damage is done is the true essence of neurological nursing.
And that wraps up our comprehensive 2026 NCLEX Neurological Review session. I want to remind you one last time to subscribe and watch the video version of this on the Super Nurse AI YouTube channel. The link is right down in the description. We really want you to keep mastering those bedside skills.
It has been such a pleasure reviewing this material with you.
Before you clock in for your next shift, I want to leave you with a final thought to just mull over. We talked about how the brain's ultimate survival mechanism to fight high intracranial pressure Cushing's reflex, forcibly blasting that systemic blood pressure up, is the very thing that eventually ends up crushing the brainstem and killing the patient if the root cause isn't fixed.
Right, the compensation kills them.
It's a compensatory mechanism that becomes a fatal double-edged sword. So as you walk the halls of your unit and look at your patient's monitors, ask yourself, what other compensatory mechanisms in the human body are actually double-edged swords that nurses need to watch out for before they turn deadly?